Thank you, all of you, for being here. It's really gratifying for me to see everyone who has taken the trouble to, in many cases anyway, come to DC, be here for our session. I know many of you were here this morning for the Sequoia sessions as well. Thank you for staying. It's always never completely certain who is going to show up after lunch. I'm relieved to see that many people, if not most people, have. Really appreciate that. So I know that many of you probably know me, but just for completeness, my name is Dave Castle. I am the Executive Director of Carequality. And for those of you who have heard me introduce myself in the past, that is a new title. It reflects the restructuring that the Sequoia project has done that hopefully many of you were able to hear from Marianne this morning, and perhaps heard a bit of yesterday from my colleagues at the eHealth Exchange as well. So the Sequoia family does still exist, but Carequality is a separate company. This is our first annual meeting as a completely separate company. We do have an independent identity. We have a separate board of directors. All of that said, it's very important for us internally, but I think the most important message for all of you to take away is nothing is actually fundamentally changing about anything that Carequality does. Carequality remains committed to our operational mission of being able to connect networks and data sharing platforms to one another. We have our steering committee, our advisory council. I know many of you are part of those bodies. Those bodies still have exactly the same role and exactly the same powers under the new corporate structure. There's primarily just a difference in who has fiduciary responsibility and who approves my budgets and such things. And hopefully, if I'm doing my job correctly, none of you have to worry about that unless you happen to be on my board. Just a quick note there. But it is nice to be able to move Carequality forward. And I think a part of what I'd like to get out of these sessions is an idea of really how we can constructively take this opportunity to look at everything we do and see where there are opportunities for change and improvement. How can we move faster? How can we move more effectively? We definitely want to hear from you, and I'll say a little bit more on that as we go along here. But first of all, just to make sure that everyone is on the same page. I think largely you're here because you're familiar with Carequality. But if everyone will indulge me for 2 minutes, I'll briefly share a little bit more about the background for Carequality. So our history really began, I guess, in some ways in terms of discussions that were held by a number of us around the industry starting in 2013. Carequality was formed in 2014. The Carequality Steering Committee met for the first time somewhere in either late June or early July 2014. And I can place it relatively precisely because I was on the steering committee but missed that meeting because I was in Ireland at the time, and the meeting occurred at around 9 p.m. Where I was. And I had it on my calendar, and the reminder popped up on my phone, and I said, you know what, I'm going to go have a Guinness instead. So the idea, though, that those conversations in 2013 started with was really a realization that there were lots of health IT data sharing networks and programs and service platforms out there. And the secondary realization was, and maybe the more important realization, certainly more insightful, was that was okay. That we didn't necessarily need to expect everyone, all different stakeholders of all different types within healthcare IT to agree on a single network platform and service. It was not something that's happened in other industries. It probably wasn't going to happen in health IT either. But what we did need to make sure was that the participants in these various programs and networks were able to interoperate with one another using those networks and existing investments as a base. So what we didn't want to say was, we have a better network, come join ours instead. What we wanted to say was, keep your network. They're doing great work. You're getting great value there. You joined them for a reason. But you don't want to have to join 10 networks. You just want to join one. And so therefore, the role of Carequality will be to provide that overlayer of governance that allows those networks to connect to one another. And example that we use that I know, and again, indulge me, a number of you have heard me use this example multiple times, but the cell phone industry and what they've done to connect different cell phone carriers is conceptually very similar to what we're doing here in health IT. So as a consumer, you subscribe to AT&T or Verizon. I live in a weird corner of the Midwest, and I actually subscribe to US Cellular as opposed to one of the main carriers, because they provide coverage in the town where my in-laws live, and no one else really does. And so I use US Cellular for that reason. But I can make phone calls, and I can reach all of you without having to think about it, who use AT&T and Verizon and T-Mobile and what have you, because behind the scenes, the telecom industry has this framework that says how those various carriers will connect to one another, that lays out legal considerations and technical specifications and a whole bunch of other things that I don't actually know anything about the details of, but they exist, and they're largely transparent to us as consumers. On the health IT side, the role of Carequality is to allow a provider organization, a payer, or some similar stakeholder to join one network, have a single on-ramp, as it's often referred to, but then make phone calls, if you will, universally to all the other participants and all the other disparate groups that are out there connected via the constituent networks and data sharing services that make up the Carequality community. So I'll stop there. I know I'm preaching to the choir for the vast majority of you, but as I always say, and many of you have probably heard me say it on our monthly information calls as well, I always want to make sure that everyone is on the same page. So that's Carequality at its basic level. So fast forward a little bit through the history of Carequality. I think it's worth just taking a pause and looking at our progress over time. We had that first steering committee meeting without me, and somehow it managed to still succeed in 2014, in late June, early July. We went from there. We established some initial working groups that really didn't ramp up fully until late fall 2014. The first order of business was to develop what we called our principles of trust. And those are still the foundational element behind Carequality. As we looked at this broad ecosystem that we were envisioning, what actually makes that work? What actually makes it possible? And the answer was trust. How can we get these disparate players who have very real security and privacy considerations about the information they hold to share it with others? Well, they have to have some basis for trust in the other party that's asking for this data. So we established our principles of trust. The principles in themselves are wonderful. They're foundational. They absolutely drive a lot of how Carequality is structured. But at the end of the day, they're principles. They're not necessarily operational on their own. So the next step after those principles of trust were adopted, we took in early 2015, was to start turning those into an operational set of documents that serve as the foundation for actual operational exchange via Carequality. Those are our Carequality connected agreements, the contract that our implementers sign, our initial implementation guide, and some other supporting documents around technical security and the like. All of those things were adopted by our steering committee at the end of 2015. And then there was a period of actual implementation by actual implementers, which took some time and continues to take some time. But the first transactions for Carequality occurred on July 1st, 2016. I got a text from Stephen Lane, and I remember that very clearly because it was the start of the 4th of July weekend. It was a Friday evening, and in his time in California, Stephen was just finishing up his day and had done the first Carequality queries and texted me about it, and I said, woohoo. To paraphrase, it was a very nice way to go into that long holiday weekend. That was more or less 2 years to the day from the founding Carequality steering committee meeting. So we had gone from that first idea in 2 years to actually having it be operational. Since then, we've seen a lot of success, I think it's fair to say, a lot of success in enabling a lot of exchange of information. The latest count that we have, we estimate that there is around 14 million documents that are being shared on a monthly basis. I think the grand total now is, if we sort of assume forward that 14 million, and it's probably a conservative to do so, we're somewhere around 75 million documents that have been exchanged. And what does that number mean? It's a little bit hard to evaluate on its own. You know, it's a big number. If you gave me $75 million, I would be happy. But what does it actually mean? I don't know. That's a little hard to say. What I think is more interesting is the growth curve and the fact that fully half of those 75 million documents have been exchanged in the past 3 months. And we've seen a real inflection point over the past 5 or 6 months in terms of serious growth in document exchange. Now, there is still a great deal to be done. The document exchange that we're doing, first of all, is document exchange. There are certainly other types of interoperability that are out there. Secondly, it is focused on treatment use cases where one provider is requesting information from another provider almost exclusively. You know, of that 75 million, there's maybe 100 that have not fallen into that. I might be a little bit pessimistic in that number, but clearly the vast overwhelming majority of those exchanges so far have been for treatment. And that's fine up to a point, but there's certainly a lot that we think the Carequality framework and that model of having a single on-ramp for all stakeholders to be able to do similar types of exchange, we think that there's a lot of value there that can be leveraged in other areas. And what you'll be hearing today is certainly, and tomorrow morning, is about how we continue to make document exchange better. The very next panel is talking explicitly about document content and how that can be improved, and generally for treatment purposes. But you'll also hear about how we're beginning to take Carequality governance into the world of FHIR-based exchange and open APIs, as it were. And there's some really interesting conversations there about what is the role of Carequality in a FHIR-based exchange ecosystem. And the theory that we have is that the role in that type of ecosystem can be very similar to the role that we play in a query-based document exchange ecosystem. And so looking at those operational components that you need to have a very broad-based, standardized exchange via FHIR resources is something that we're taking a look at as well, and you'll hear about that. You'll also hear about document exchange it being applied to non-treatment use cases. There's a lot to be said for the fact that an awful lot of provider organizations who are the source of information that people need and have, in some cases, a right to have, there's already a way of getting that information out of those systems. There's existing investments that have been made, and it should, in theory, be relatively straightforward to leverage those existing investments for other purposes. And so we'll be talking a bit about those non-treatment use cases as well. That said, Carequality only works as a community. And a community, in some ways, I think, is like a family where you have people who don't always agree. They have different viewpoints. Most families have the crazy uncle who comes to Thanksgiving dinner with his political views. In my particular family, I grew up in Lancaster, Pennsylvania. If you're a political junkie, I don't know if Lindsay's still in the room, I believe we were the only county or one of a very, very tiny handful of counties that has literally never in the history of the United States had a Democratic representative to Congress. So in my family, the crazy uncle was the crazy liberal uncle. But everybody has one, and part of what makes a family work is that you're still able to invite that guy to Thanksgiving, or in our case, often had him host Thanksgiving because he had a good house for it. We need to do the same thing and make sure that we have those kinds of open conversations in the Carequality framework. If we're doing something that folks on one side agree with, and maybe there's another set of stakeholders that don't agree with, we need to actually have that conversation openly. We need to figure out what is the yes-if solution, if you will. Where can we say, yes, I will exchange that information if, and then address that if in our policy requirements. So really having the tough conversations to figure out how can we break through some of the I won't call them barriers, but just hesitations and challenges that are still out there. How do we leverage the existing Carequality infrastructure to support exchange between healthcare providers and payers, for example? We can talk about that here on the stage, but we also need to figure out how to move that into reality and what are the very real challenges that we need to address in doing that. And we'll have a panel that is talking specifically about those payer exchanges. But it goes beyond payers. Really, any of these stakeholders, any of these projects and use cases that we're talking about, I want to make sure that we're really taking a look as a community and figuring out, is this what we want to do? Is this the best way to be investing our time? As we're doing it in the details, even if it overall is the best way to invest our time, we really need to make sure that we're keeping that community concept in mind and really speaking our minds and having the fierce conversations, giving the feedback to me when necessary that, you know what, this is probably not something that's going to work. We need to take it in a different way. And maybe there isn't any of that, but I want to make sure that we keep that community concept in mind, because we're all ultimately trying to get to the same place. I believe that firmly, that everyone who's here in this room has a real stake and a real belief in the power of interoperability to change healthcare and ultimately change the way patients receive value from our healthcare system. And we just need to make sure that we're really working together and pulling together as a community to make sure that that happens in the right way. And if we need to change some of our ideas and plans to make that happen in the right way, I can only do that if you tell me. So all that to say, I really hope that there's an open dialogue, not only in these sessions, but overall. I'm really looking forward to hearing from the community. I'm really looking forward myself to the panel discussions, and hopefully we'll really get a lot of interesting and useful things for you to take back, and for me to take back as well.